Hello students, welcome to MediBits with Dr. Shraddha. In today's session, we are diving deep into one of the most common autoimmune endocrine disorders, that is Hashimoto's thyroiditis. This lecture is designed especially for medical students to help you understand the pathophysiology, clinical presentation, diagnosis and management. So students, before we dive into the topic, let's take a look at what you will gain from today's presentation. By the end of this video, you will be able to clearly define what Hashimoto's thyroiditis is and understand who it most commonly affects and why. You will also learn to recognize both gross and microscopic pathology, which is essential from exam perspective, especially in pathology viva and practicals. We will then go through underlying autoimmune mechanisms, which are the foundation of this condition, followed by typical clinical features and how the disease usually progresses over time. You will get a clear idea of diagnostic workup, including thyroid function tests, antibody testing, and imaging like ultrasound. In terms of treatment, I will walk you through management strategies primarily centered on levothyroxine's replacement. We will also compare Hashimoto's with other forms of thyroiditis so that you can confidently differentiate it in clinical practice and exams. Finally, we will discuss potential complications and need to help reinforce your learning. I will include 3 NEET-PG style MCQs at the end, and which would be complete with explanations. So stay with me till the end. This one is going to be both clinically relevant and exam oriented. Hashimoto's thyroiditis, also known as chronic lymphocytic thyroiditis, is an autoimmune disorder where the body's immune system attacks the thyroid gland. It is the leading cause of hypothyroidism in areas where iodine intake is adequate. The condition was first described by Dr. Hikaru Hashimoto in 1912, and it remains one of the most studied autoimmune diseases to this day. So students, who gets Hashimoto's? This condition predominantly affects women with a striking female to male ratio of nearly 10:1. Most cases present between ages of 30 to 50 years. It is also strongly associated with other autoimmune diseases like type 1 diabetes mellitus, rheumatoid arthritis, systemic lupus erythematosus, myasthenia gravis, Sjogren's syndrome. A family history of thyroid or autoimmune disease increases the likelihood of developing Hashimoto's. So students, now we will understand the pathophysiology, that is how does it happen. The immune system, particularly T lymphocytes, targets thyroid antigens, most notably thyroid peroxidase, that is TPO, and thyroglobulin, that is TG. This leads to chronic lymphocytic infiltration, destruction of thyroid follicles, and eventually fibrosis. The gradual destruction impairs hormone production, leading to hypothyroidism. It's important to remember that this is not a sudden process. It evolves over months to years. So now we will understand the gross morphology of Hashimoto's thyroiditis. The thyroid gland in Hashimoto's appears diffusely enlarged and firm. Its consistency is rubbery due to fibrosis and lymphocytic infiltration. The cut surface often appears pale, grey tan and lobulated. Nodularity may be present, and although the enlargement is usually symmetric, some patients may show asymmetric thyroid involvement. So now we will understand the histopathology of Hashimoto's thyroiditis. Microscopically, Hashimoto's thyroiditis is characterized by intense lymphocytic infiltration forming germinal centers. You will also see Hürthle cells. These are follicular epithelial cells that have undergone oncocytic metaplasia with abundant eosinophilic granular cytoplasm. Follicles appear atrophic and disrupted. In chronic cases, you will notice progressive fibrosis. This microscopic appearance is classic and can be diagnostic even in fine needle aspiration cytology. So students, you can see the germinal centers over here. These are the collection of lymphocytes. Okay, and these pink colored structures are the thyroid follicles showing Hürthle cells. Hürthle cells are eosinophilic follicular cells which have undergone oncocytic metaplasia due to chronic injury. This is the close picture of Hurdle cells. You can see these pink colored structures. So these are follicular cells which have undergone oncocytic metaplasia. So students, how does Hashimoto's thyroiditis present clinically? Patients often present with non-specific symptoms like fatigue, cold intolerance and constipation. On examination, signs like dry skin, bradycardia and sometimes a goiter may be present. Interestingly, in early stages, patients may have normal thyroid function or even transient hyperthyroidism due to follicular destruction, a state known as Hashimotoxicosis. So how can we diagnose this clinical condition? It relies on lab findings, most notably a raised TSH and low free T4. Anti-TPO antibodies are positive in about 90 to 95% of cases, while anti-TG antibodies may also be present. Thyroid ultrasound typically shows a diffusely hypoechoic and heterogeneous gland. If nodules are palpated or seen on imaging, fine needle aspiration cytology may be needed to rule out any malignancy. How can we treat this condition? Treatment involves lifelong thyroid hormone replacement, typically with levothyroxine. Dosing is weight based and adjusted based on TSH levels, which should be rechecked every 6 to 8 weeks during titration. Once stabilized, annual monitoring is usually sufficient. The goal is symptom relief and normalization of TSH. So students, if untreated or poorly managed, Hashimoto's can lead to severe complications. Myxedema coma is a medical emergency characterized by altered mental status, hypothermia and multisystem failure. Chronic hypothyroidism also increases the risk of infertility, cardiovascular disease and in rare cases thyroid lymphoma. Several types of thyroiditis can mimic or coexist with Hashimoto's. Subacute thyroiditis is painful, usually post-viral. Postpartum thyroiditis occurs within a year of delivery and often resolves spontaneously. Riedl's thyroiditis is rare and involves fibrous replacement of thyroid tissue. Understanding the distinctions is critical for accurate diagnosis and management. To summarize, Hashimoto's is an autoimmune thyroid disease marked by antibody-mediated destruction of the gland. Anti-TPO antibodies are key for diagnosis. It's much more common in women, often presenting in midlife. Early diagnosis and appropriate thyroid hormone replacement can prevent complications and restore quality of life. So now we will go through MCQs. There are total 3 MCQs. So first MCQ concerns a clinical case in a hypothyroid woman. So students, please focus on the key areas of information. So the question consists of 38-year-old woman presents with complaints of fatigue, weight gain, cold intolerance and constipation for the past 6 months. On examination, she has dry skin and a mildly enlarged non-tender thyroid gland. Her lab values are TSH 12.8 that is increased, free T4 0.5 that is decreased, anti-thyroid peroxidase, anti-TPO antibodies are positive. What should be the most likely diagnosis? Your options are Graves' disease, Hashimoto's thyroiditis, subacute thyroiditis or Riedel thyroiditis. So now we will go to the next slide which consists of the answer. So the correct answer consists of B. Hashimoto's thyroiditis. Why? Because the patient presents with classical symptoms of hypothyroidism. Presence of a non-tender goiter, high TSH, low T4 and positive anti-TPO antibodies confirms Hashimoto's. Now we will discuss about the remaining options. Graves' disease typically presents with hyperthyroidism. Subacute thyroiditis is painful and often post-viral. Riedel's is rare. and presents with woody hard thyroid and compressive symptoms. Now next MCQ2, which is a spot pathology slide. Question consists of a thyroid biopsy from a patient shows lymphocytic infiltration with formation of germinal centers and presence of oxyphilic Hurdle cells. What should be the most likely diagnosis? Your options are multinodular goiter, Hashimoto's thyroiditis, papillary thyroid carcinoma, or decurvens thyroiditis. So the correct answer is B, Hashimoto's thyroiditis. Why? Because lymphoid aggregates with germinal centers and Hurdle cells are hallmark features of Hashimoto's. The remaining options, that is multinodular goiter, doesn't show significant lymphocytic infiltration. Papillary carcinoma of thyroid shows orphan ani nuclei and psammoma bodies. Decurvens is characterized by granulomatous inflammation, not Hurdle cells. Now we will discuss the last MCQ of this presentation, which is related to pregnancy and thyroid autoimmunity. The question consists of a 30-year-old woman, 3 months postpartum, complains of fatigue, mood changes, and mild neck discomfort. TSH is low, T3 and T4 are high, and anti-TPO antibodies are positive. Thyroid scan shows decreased radioactive iodine uptake. What is the most likely diagnosis? Your options are Graves' disease, subacute thyroiditis, postpartum thyroiditis, or silent thyroiditis. So the correct answer is C, postpartum thyroiditis. Why? Because postpartum thyroiditis is a variant of Hashimoto's occurring within 1 year of delivery. It often has a biphasic course, transient hyperthyroidism from follicular destruction followed by hypothyroidism. Positive anti-TPO antibodies, low uptake on scan, and absence of eye signs rules out Graves'. Subacute thyroiditis is painful and post-viral. Silent thyroiditis is similar but not postpartum related. So students, thank you for watching today's episode on Hashimoto's thyroiditis. Please don't forget to like, share and subscribe to MediBits with Dr. Shraddha channel. If you have any questions or topics you would like to be covered, drop them in the comments. In the next video, we will be tackling papillary carcinoma of thyroid in a similar high yield format. See you then.